Good afternoon and happy Stroke Week. Thank you for joining us today for our first webinar this week. We'll be getting started very shortly. We'll just give people a chance to log on and get settled. While everyone is logging on, please make use of the chat function and let us know what site and state you're from. You may even be joining us from outside of Australia, and if so, we'd especially love to hear where you're joining us from today. I can see lots of people logging on now, which is fantastic, so we'll get started. Good afternoon again and welcome. My name is Ashley Mamo. I'm the Stroke Webinar Coordinator here at the Stroke Foundation. I'd like to introduce to you our presenters for today. We have Michelle Courtney-Harris and Neryla. Michelle is an experienced clinical orthoptist and lecturer at the University of Technology, Sydney. Michelle has recently completed a PhD focused on visual problems in stroke and related ocular conditions. She has also worked to create a validated vision screening tool and an accompanying e-learning module, and we're going to be hearing more about that in part 2 of this session on Friday. We're also joined by Neryla. Neryla is an orthoptist at Royal Ryde Brain Injury Unit and in private practice testing patients for vision and driving standards. Neryla's clinical experience has disclosed the importance of vision in daily living skills. Her research involvement has been in the areas of stroke and brain injury and their impact on vision. So on behalf of Stroke Foundation, I'd like to thank both you, Michelle and Neryla, for sharing your knowledge and expertise with us today. We're all really excited to learn from you, and I think that's evidenced by just how many people have registered for today's session. I'd also like to welcome Leah Pett, who is Stroke Foundation's Senior Project Officer for Stroke Unit Certification. And Leah will be here to facilitate our discussion time in the second part of this session. Before we begin the webinar, I'll briefly run through some housekeeping. An interactive webinar is a good webinar. We encourage you to use the Q&A function at the bottom of your screen to submit your questions as you think of them. And we'll answer your questions in the second half of the session. If you see a question that someone else has asked that you also want answered, you can click the thumbs up button under the question to vote for it. All registrants will receive an email with the resources mentioned and a link to the recording. And at the end of this session, there will be a short survey where you can also register to receive a CPD certificate. Now, please note with this survey that it will close 1 week from today on Monday, the 15th at 5 p.m. Australian Eastern Standard Time. So I encourage you to fill that survey out as soon as this session's over so you don't forget. Before we begin, we would like to acknowledge the traditional custodians of the lands on which we all meet today and pay respect to elders past, present, and emerging. I'd like to acknowledge that I'm joining you today from the lands of the Darkinjung and Gurungai people. I'll now hand over to Michelle and Neryla to begin the presentation. Thanks very much.
Thank you, Ashley. Just to begin, I thought I'd give you a little bit of a snapshot of the vision issues that you might see in your stroke survivors. Literature reports that up to 92% of your stroke survivors will have some form of visual impairment. Now, these are not always from the stroke. They can also be pre-existing conditions and age-related conditions that they might present to the hospital with. A lot of the vision difficulties can actually go unrecognised when a patient is actually admitted to hospital. You need to realise that when a patient is admitted, there's lots of things going on, and the staff are very keen to attend to the patient in a way that their survival is a key point. So the fact that a person might have some sort of visual issue tends to be forgotten rather quickly. A lot of the average stroke patient is 65 and above. Now, we do know that stroke can impact at any age, with about 25% of those under 55 But the fact that a lot of these patients are 65 or greater does mean that they are going to, they're in a much higher risk category and are very likely to have some sort of associated age-related ocular disease when they come into the hospital. The other thing you need to make a bit of sense of is good versus poor functional vision. There's two ways vision is represented. There's a measure of vision and then there's functional vision. And these are two completely different things when you think about it. And you need to sort of step into the patient's shoes a little bit, because without actually having some form of visual impairment yourself or some sort of visual issue yourself, it can be quite a challenge to actually imagine what that patient is actually seeing. So what I've tried to represent here is I've just taken a picture of how someone with what we call normal visual function might perceive the world. We can see that there's a nice arch there. It's made of some sort of sandstone or concrete with some trees around it. But someone with a visual impairment might have that picture looking washed out. There could be missing objects, could be very dark. They may be lacking in contrast. So these are some of the things that your patient might actually notice in the ward. So they'll have issues seeing you walking into the clinic, into the actual ward room itself. They might have trouble, definitely will have trouble with mobility as well. So just something to consider when you are seeing these patients. So understanding what your person or what the stroke patient is actually seeing can be very crucial to recovery and rehabilitation. And what I've got here is I've actually made some images just to simulate what it's like for someone who might have a visual disability. So I've tried to emulate double vision. So we've got this sort of ghosting appearance, and you can see how it can be quite annoying, I suppose. So if you imagine having that double image of everything that you look at in your surroundings, your patient will be quite frustrated. Then I've got some image there of, it's supposed to depict a bit of glaucoma or even macular degeneration and diabetic retinopathy, where we have this distortion in our vision. We have our visual field can be impacted both centrally and peripherally, and it can impact the way a person might see something, to be able to write, to read, and even respond to patients or to doctors themselves. When we were coming up with the talk today, Neryla and myself were thinking about what are some of the key ways that vision can impact your patient that you need to be aware of. So we came up with these 4 headings, and these are probably, if we can stay in this sort of frame of mind, you can't sort of go wrong when you think of your patient. So when you present your patient, think, okay, well, is there something wrong with their central vision? Because if there is something wrong with central vision, they're not going to be able to see faces, they won't be able to see detail, they won't be able to read and write, and they will have issues with mobility. Then we have peripheral vision, where their world is quite constricted. They might be bumping into objects. Their mobility, their ability to walk around will be very slow, and they'll have a lack of confidence in their movement as well. Are there any eye movement disorders? So the world might think of it confused, jumbled, or even blurred vision. And the other big one to consider is watery eye, a very topical condition at the moment. Everyone seems to be suffering from watery eye, but the thing you don't know about watery eye is it can impact vision quite significantly. So you do need to be aware of that, like in your patient. What I've done here is I've just tried to put in a slide some of the differentials in the types of conditions that you're going to see in your patients. And I've sort of labeled them as non-stroke and also stroke related. And you can see here with our symptom of blurred vision, which is one of the common things that patients can actually describe, is I'm just having trouble with my vision, things don't quite seem as clear. Now, in a non-stroke scenario, these are your patients over the age of 65 and above. They could have, or even under 65, refractive error is probably a leading cause of blurred vision. Having someone with their glasses and their correct glasses is quite important to have in the clinic. We have cataract. There may be corneal abrasion or scarring that can be possibly a long-standing thing. Dry eye and retinal disease are quite primary in causing blurred vision, and also optic nerve disease. Now, when it comes to something that's being instigated by someone from a stroke, these patients can have accommodation anomalies. And this is because the area where accommodation is generated is in that visual cortex area. Then we've got reading difficulties. Again, our main culprits coming up again, refractive error, cataract, retinal disease. But in regards to the stroke patient, we might also need to consider things like gaze palsy. So is there some sort of interruptions to the way their eyes move together? Because when you are reading, you do need to focus on an image and you need to have nice, steady concentration on that, what you're reading there. Diplopia. I know you may hear about diplopia in stroke-related conditions, but diplopia is actually existent in pathological conditions, primarily in cataract. It's not binocular diplopia, but it's what we call monocular, so it just occurs in one eye. And if somebody has what we call a decompensating phoria or an acquired strabismus, they may have had that for a long time period. And if they have another illness like a stroke, that sort of extra illness can break it down and they can have visual ocular motility problems. Our next big one is our loss of visual field. And we do know that with stroke, we get visual pathway lesions, which can lead to hemianopia and quadrantinopia, especially if the temporal or parietal lobes are impacted, if the occipital lobe is also impacted as well. But there are lots of pathological conditions and age-related conditions where we can have visual field loss. Some of our glaucoma is our big one, where our world tends to constrict down. We get that central vision remaining, but our peripheral vision goes. But there are quite a lot of retinal dystrophies, particularly macular degeneration, diabetic retinopathy, hypertensive retinopathy, and even a space-occupying lesion, which can cause a visual field loss to occur. Then we have our perception abilities. With cataract being a pathological derivative there, it can cause glare problems. We can have reduced vision. And if you have refractive error, we can also get some perception problems. But when we talk about stroke, we're looking at our neglect and our visual field loss linked there together. So I was just trying to bring up here that even though the symptoms are evident in both, they are from very different orientations. Refractive error is something that can impact all ages and is probably one of the simplest things that we can correct in the clinic. As I said, when a patient comes in, they can be quite concerned about their other health options, and they may have forgotten their glasses. It's quite common that over the age of 50 that all patients require reading glasses, and if you've got reading glasses, you don't always necessarily need to have glasses to help you see in the distance, but they're the ones who are probably more likely to miss not bring their glasses in. But we have our top refractive errors there. We have myopia, so somebody who is myopic will have lots of troubles seeing far away in the distance, but they may be able to see quite well up close. Someone who has hyperopia will have issues seeing far away and up close and sort of in that mid-distance. With astigmatism, they have this blur in all avenues, so both up close, far away, and we have our presbyopia. So if you suspect that a person may not be seeing quite as well, it's always a good idea to possibly ask them, do they wear glasses? Have they ever worn glasses? One of the big challenges is a lot of patients who may have worn glasses in the past may have had laser refractive surgery, or they may have had cataract surgery. And technology today enables us to be able to change the shape of the front of the eye, the cornea, so that they don't need to have glasses. So that's another sort of level on top of that as well. Always something to bear in mind. For your younger patient who may have a refractive error, they may be a contact lens wearer. And if they are wearing what we call extended contact lenses, which means they basically pop the contact lens in and it stays in for a whole month, if they happen to have had an incident and they've been wearing their contact lens, you need to be mindful of that it would be better if they actually take the contact lens out, but they need to have their glasses to put on a replacement. If not, you do need to ensure that the eye does remain lubricated. So putting lubricants in their eye at regular time zones will be advisable in that situation. Just going back to cataract here, occurs to anyone over the age of 55. There are a number of causes for cataract. The symptoms do include reduced vision and glare problems and that monocular diplopia. But the thing with cataract is, even though everyone, if they live long enough, will develop cataract, there are systemic diseases and medications and lifestyle which can actually trigger cataract to begin a little bit earlier. And one of the big things there is diabetes and hypertension can actually bring on cataract changes a little bit earlier in life. We have age-related macular degeneration. One is a leading cause of the visual impairment worldwide. 1 in 7 Australians over the age of 50 will have some sort of evidence of AMD. What you do need to know that there are 2 types of AMD. We have a wet type and a dry type. The more destructive type is the wet type, where we have bleeding that occurs at the macular area. And this is what really impacts our central vision. We get distortion and blur. We have these edges that appear sort of bent and sort of misaligned. This it's age, smoking, and family history are very big risk factors. And I've thrown smoking here, and smoking is also another risk factor for stroke as well. So there is that possibility that your patient may have beginnings of age-related macular degeneration. The important thing to remember here is, if your patient does have what we call wet macular degeneration, it's quite likely that they are on treatment, and that treatment is ongoing. And if that treatment happens to be paused for extensive periods of time and that bleeding restarts again, then the level of the vision that they had can be impacted quite dramatically. So it's something that does need to be kept at the back of the mind, and make sure that they aren't currently undergoing some sort of treatment. Coming into other retinal conditions that affect vision, we have a retinal detachment that it can impact anyone at any age. And it's linked to high myopia, injury, and trauma. So that's something that you might see in your younger stroke patients. Diabetic retinopathy, hypertensive retinopathy, and the big one here is what we call vascular occlusive disease. And in actual fact, a patient might present to an eye clinic with either a central retinal artery or branch retinal artery occlusion, which is actually a precursor to stroke. And if somebody does come into the ophthalmic clinic, we would always put them on to refer them on to actually have further investigations, because the likelihood of them actually having a stroke within the next 2 to 3 weeks is actually relatively high. The thing you need to take aware of is with a retinal artery or vein occlusion, you can have severe vision loss, and it's a sudden loss. Basically, your patient, they might say, oh, I've just been having these interrupting, my vision sort of comes and goes, and then they might say, look, I've just woken and my vision has completely gone. They're the more serious ones that we need to be aware of. As I mentioned, this is our precursor to stroke. Glaucoma, it's a group of diseases where vision can be lost, and this is where the retinal nerve fiber layer and the optic nerve at the back of the eye can be impacted. It's a major cause of visual disability and blindness. It typically doesn't have any symptoms until later in the disease. Up to 50% of glaucoma cases are technically undiagnosed. There are a level of patients who are at quite risk of developing glaucoma, and usually if you're over the age of 40, your risk sort of doubles every decade of life as you get older. If you have other family members who have been diagnosed with glaucoma, then the risks are much higher as well. The vision loss with glaucoma is permanent. Once the damage is done, you can't get it back, which is why it's very important to catch it nice and early. There is no cure, and treatment is lifelong. The most prominent treatment for glaucoma is medical management, where your patient might be required to put drops into their eyes every day. And if these drops do happen to be discontinued, which means the management of the glaucoma progression has not been controlled, then the risk of them losing more permanent damage is quite great there. So if you do have a patient who has been diagnosed with glaucoma, please ask what type of treatment they're on, and if they are taking regular medications, and you do need to maintain those drops. Visual field loss. Yes, it is highly associated with stroke, but you also need to be aware that not only stroke can cause a visual field damage, we can get unilateral visual field loss when we have pathological changes that do occur at the level of the retina and the optic disc. And particularly with glaucoma, or if we have some sort of diabetic retinopathy or retinal detachment and AMD, especially if the damage is severe enough that we have this atrophy occurring at the retinal level layer. You can also get cortical lesions where we get that bilateral field loss, and that's quite typical with stroke lesions. I just wanted to show you, this is an example of retinal disease. So this is a retinal disease that has impacted the visual field. So this is retinal photography, and this is what we call an branched artery occlusion. And you can see, if I can use my cursor, you can actually see this area here, this whitening of the retinal area. And that particular, what's happened there is the blood vessel has been blocked, and you can actually notice there's some sort of blockage happening here. So that area of the retina has lost its nutrients and its feeding of blood, and has actually died off and become atrophied. And what that happens is, even though this is an inferior damage here, but we get this superior visual field loss here. So a patient would have troubles seeing things up above them. So if they're in the low hanging, or if somebody comes from above. What I've got here is, we can see that we've got all these nerve fiber layers at the back of the eye, and you can see how that they are quite mapped. And if you do get some sort of bleeding that occurs at this level, that those nerve fiber layers are going to be damaged. What's that? The other thing I wanted to point out is dry eye. The definition here is there's a lack of sufficient or quality lubrication of ocular surface. The prevalence of dry eye increases with age, and between the ages of 50 to 80 plus, there's a 50% chance of a patient being admitted with stroke who may have dry eye. I have dry eye. I'm constantly using my lubricants all the time. And unfortunately, it is something that is much more common in females more than males, especially around that menopause time as well. If your patient is using contact lens use, so in your younger patients, if they have a refractive error and they've been using contact lenses, they're quite likely they're going to have dry eyes. Indoor environments, air conditioning, humidity, being outdoor in windy environments, these all aggravate the symptoms of dry eye, which can actually be quite debilitating. Some medications and smoking can actually bring on dry eye. So a lot of your antihistamines, or anything that sort of dries up the mucus glands and things like that, can lead to chronic dry eye. And if you have any structural changes to the eyelids themselves, so if there's any scarring or any if they've had surgery or something to that, or if the eyelids, what we call atrophy, they tend to sort of droop out or bend out, they lose their elasticity, so it can't capture the tear film, then that can cause dry eye as well. Now, these are just some of the symptoms that patients complain about. Their eyes are tired, they have red eye, they're itchy, they're stinging, they might have constant watery eye, which sort of, you think, okay, the eye is dry, why is the eye watering all the time? But it's your eyes are basically producing more tears to compensate for the lack of tears that are sticking to the corneal surface and giving that nourishment and that moisture. And it can be, dry eye itself can be very frustrating, and there might be a number of you out there who already have dry eye. So you can sort of sympathize with what these patients are going through. So next section we're going to go on to is eye movement disorders. And for this component here, I'm actually going to hand over to Neryla for this component.
You want me to talk about this now?
If you'd like, or we can go through. Well, I suppose what you need to know is there are specific pathways in regards to the way the eyes move. And these pathways typically start cortically, and then they descend through various nuclei and through the brainstem. And we're quite aware that a lot of stroke infarcts do occur in and around the brainstem. When these signals become interrupted, we get what we call eye movement abnormalities. And what happens is that you get ipsilateral and contralateral movements that are affected or impacted in that way. When we have oculomotility disorders associated with stroke, we have what we call cranial nerve palsies, gaze palsies, and nystagmus. Now, these are conditions which you may already be familiar with. You may have already been a witness to them. Your patients will complain of diplopia, blur, and confusion, and that can be very frustrating for the patients themselves. Some of the things you need to be mindful of is recovery of oculomotor disorders can be very dependent on the location and type of lesion. When we have those who are associated with microvascular etiologies, they can have recovery, especially in the first few weeks, but it can take up to 3 to 6 months for that to occur. Brainstem lesions are a little slower in the recovery and can be anywhere up to 12 months for that to sort of have some sort of redemption in any way, but recovery is less likely. When you have oculomotor disorders, it can be a little bit challenging to actually recognize that your patient has them, because sometimes the movement itself can be very subtle. And if you're not well versed in what you're looking for, the very obvious gaze palsy we can always see. One eye's either in, one eye's out, up or down. So, but it's the smaller lesions which can be a little bit more trickier, and that's where the patient, you need to listen to what your patient is actually saying to you in regards to their vision imperfections, because those smaller lesions, the person may not actually say, oh, I see double. They might be more presenting, you say, oh, everything's quite blurred. Okay, or I've got a ghosting, or things just aren't, a little bit confused there. Okay. With a bilateral fourth nerve, these rarely recover, and our cerebellar lesions can take anywhere up to 6 to 12 months to recover. Get Neryla to come in on.
Take over. Right, thank you. What I'm going to do is to talk to you about working with allied health practitioners and nurses and doctors within the clinical environment. And I've been thinking about this a lot. One of the keywords that I would put to you is frustration. I've had patients come into the eye clinic and say to me, I've been trying to tell someone there's something wrong with my eyes and nobody is listening to me. Thank goodness I'm here. Because the eye conditions can be so subtle that they just don't seem to be important against all the other problems that they've got with their stroke. And I quite understand the health community being concerned about the survival of the patient, but these patients are in rehab. They need that little bit of extra attention. So if you're hearing the frustrated call, start thinking about eye conditions. The other side is listening to staff. I'm fascinated when I hear staff saying, I don't know what's happening with this patient. Sometimes when I get them to do something, they do it so well. And then the next time I get them to do something, they can't do it. And I sort of sit back and think, right, well, let's do a vision test. Because it's very possible that they've approached the patient from one aspect, and the next time they've approached the patient from a different side. The first time they did it when the patient cooperated, they did it from the side where the patient could see. When they did it the next time, they did it from the side where the patient couldn't see. And typical of this is where they put meals. If a patient has a peripheral vision loss and they put the meal on the seeing side, the patient will pick the meal up and eat it. If they put it on the unseeing side, the patient's sitting there saying, when's my meal coming? It can be just as simple as that, but the staff feel frustrated because the patient is not consistent in their cooperation. So take the word frustration and think about it when you're working with your patient. Is it an I-cause thing that's causing the patient not to respond? So Michelle's given you a fantastic overview of all the kind of eye conditions that can happen in a stroke patient. It is just amazing. What I'm going to do is just go through and bring you some of the clinical responses that happen with these patients. As I've written here, eye conditions can be pre-existing or newly acquired, and Michelle has already told you this. First thing I would suggest you do if you're in direct contact with a patient is ask the patient and all the relatives about glasses and where they are. Ask about existing eye treatments and what's been carried out, and have any glasses and drops brought in from home to the hospital. And if necessary, have them replaced. I will go on and talk about these glasses in a moment. It gives me the giggles sometimes. I mean, I find we can't be tense. We have to be happy to help these patients move through. And I'm going to talk to you about my experiences with patients in the ward in the areas of central vision, peripheral vision, double vision, and eye movement defects, because it kind of summarizes the wealth of information that Michelle has given you. And I find we have to educate the patient, the family members, and other staff about the area of the defect. And I can't say more clearly that you can't do a lot about the vision defects. We do have to refer these people onto an eye care specialist. Can I have the next slide? Thank you.
So we're just recapping our main points, our central vision, peripheral eye movements, and our water eye, and the types of symptoms that these patients might actually complain about. And then we'll move into our first one here, which is central vision.
Central vision. So some patients have good vision and others need glasses. The pictures are sort of going over the top of. And the others, there may be some patients who are actually blind. And I was stunned by one particular patient who was blind. He could tell us the most incredible stories about what he could see. But in reality, when we got down to it and were very cunning about it, we found out he was blind. Now, glasses. If you ask the family to bring in all the patient's pairs of glasses, even if the patient is not communicating very well, you can pick up a pair of glasses and say to the patient, these ones? And they can go, or If they say, get rid of them. And you keep going through all the pairs of glasses until you find the pair, they go, and then you find out about them. Now, you need to also remember these glasses may be reading glasses, therefore really good for the occupational therapist or the speech pathologist. And I have a great relationship with a speech pathologist who loves me to tell her about the glasses so the patient can get on and do the activities that are needed. Be aware that patients have a wonderful ability to collect glasses from the relatives in the past history. And so you may have great Uncle George's glasses from years ago that somebody will bring in from home and try and put on, and they've got nothing to do with what the patient needs. So we need to find the actual pair of glasses that are going to be useful to the patient. I've put at the bottom that they need to be seen by an eye care specialist. And somehow we do need to get them for their glasses checked by an optometrist. They're the ones that are going to give them the actual good pair of glasses that is going to get them going. Now, I'll give you another really good example of a patient whose glasses got lost. The patient lay in their bed and wouldn't do anything. They would eat. And actually I was able to, as an orthoptist, get some glasses going for this patient, and I found out he was short-sighted to the power of -350. The optometrist very kindly made these up for me because we were in COVID, couldn't get the patient out. As soon as he got these glasses, this patient got out of bed and started doing physical activities. Glasses can make a huge difference to the mobility and interaction of the patient in your rehabilitation environment. So central vision and use of glasses are very important, but be aware they may be the wrong pair. So we need to follow through and make sure they are the right pair of glasses. Thanks, Michelle. Next one, peripheral vision. Michelle's referred to this. So a patient can have lost half or quarter of their side vision. They can be aware of it. They will tend to move their eyes around when they've lost a quarter or half of their vision. They tend to compensate for it, but they're not comfortable about it. That they will be upset, agitated more than anything. And once you're aware of what part they lost, if you can stand on their intact side or offer your rehabilitation on their intact side, you'll get on much better with them and they will make progress. Please be aware that this field loss is not going to go away. It's going to stay there. It may go away in 6 months in some unusual situations. One thing that you need to do, and you can encourage your patients to do, if say they've lost things on the left-hand side of their world, is encourage them to look over to the left, particularly if you're wanting as a physio to get them walking. Get them out of the bed, ask them to look over to the left as they walk, look over to the left as they walk. So they're using their intact right side to compensate to the left. If you're wanting them to eat a meal or do an occupational health therapy activity, look to the left to do it. Look to the left to do it. If you're wanting them to read, then I think this is where that red colored band comes in on the side of the activity where you're wanting them to read or do something. Look to that band. What can you see while you're doing it? Look to the left. Keep emphasizing the side where they've got the problem. Now, I've mentioned a thing called neglect. Neglect is an absolutely fascinating thing. A patient can have an entirely full field, but the right side of their brain does not allow them to be aware of something on the left. And it sets up that gorgeous situation in the clinical environment where somebody can come in and stand on the left-hand side of the bed, and there'll be somebody on the right-hand side of the bed, and the left-hand side person says, "How are you today, Mrs. Brown?" And Mrs. Brown looks at the person on the right who's not saying anything and says, "I'm fine today, thank you very much. Are we going to go for a walk?" Person on the left-hand side of the bed said, "How was your headache that you had yesterday?" "Oh, it's not here today. That medication you gave me yesterday is really good." That's neglect. It's an extraordinary thing. I think I've covered everything there. Can I go on to the next one, please? Double vision. Double vision is something that Michelle again has referred you to it. It's due to muscle problems. It can be everywhere, or it may only be in one direction. How patients will cope with this when you're seeing them is if it's on one side or in one position, they won't look over there, or they'll tell you that it's over there. But what patients most regularly will do is something like this, sort of cover over one eye or pull their eyelid down. They don't want to see the double vision. They don't enjoy it. And I guess you would understand that. What they need to do is to have one eye covered. And you need an eye care person to correctly cover the correct eye. when you've got double vision, if you cover the correct eye, the unaffected eye will do all the right depth judgment and location of objects. If you cover the unaffected eye and make a person use the affected eye, everything is out. So instead of pointing directly at something, they'll misjudge it. So if pouring a cup of tea, they'll pour it onto the table. If trying to get with their fork into the piece of food, they'll misjudge it and they'll get so upset, it won't be a good thing. So somebody in the eye care world has to be able to identify which eye needs to be covered and how it needs to be covered. It can be on a pair of glasses if they have them, or an eye shield. Eye pads that are taped on are not very comfortable because you can't open your eyelid underneath. An eye shield that goes over with the elastic around it is really good because the eyes can open underneath. Thanks, Michelle. Next one. Eye movements. Now, with eye movements, you might find the person cannot move their eyes in certain directions, so that this is both eyes not being able to look from one side up or down, or not look to the left. So they're all right looking over this side, but they get blocked looking to the left or right. And this is pretty obvious to see from your point of view. Again, don't push them. Let them move their head to go over to the side where they can't look. The other one is nystagmus. And this is one where you have to get close to the patient quite often to see it, where they have a sort of a shaking of their eyes. And I've got a particular patient at the moment with this nystagmus. She has a very bad nystagmus in looking into left gaze, but on right gaze, it's very minimal. And I've actually got her into doing some exercises where she moves her eyes intentionally to the right and the left and up and down. It's an exercise that we refer to as doing the Union Jack. I've now found that she can now smoothly look to the right without nystagmus and has good vision and is comfortable with this, and going to the left is better, but still not good and still not comfortable. But now she's mobilizing much better as she can start to swing out to the right and start to get up and walk around. Nystagmus is a monster because with the instability of the eyes, the whole world is shaking. So being able to locate things, being able to get out and walk around is an entirely uncomfortable thing. Sometimes with nystagmus, bringing objects up close, the muscles lock in and the nystagmus becomes less. Again, you need support of an eye care specialist to identify nystagmus and the null point, or the point of minimal movement of the eyes. Thanks, Michelle. So some steps here on finding an eye care specialist. If you're in a big hospital, you will have an eye clinic. So it's good to ask them if you can send the patient down to the eye clinic to have them see the patient. If you're in a situation where I'm at Royal Ride, which is fabulous because I'm employed specifically to see the patients, identify the eye conditions, to inform all the other staff on what the eye condition is, what to do about it. So very lucky. But if there is any kind of eye condition, I will get this patient referred out to a private ophthalmologist. And so we have a group of them that is close to the hospital where the patient can be seen. And if the patient needs glasses, then they're referred out to an optometrist. And we've got one who's very close to the hospital. So this is where the way I'm working at Royal Ride. Michelle is going to tell you on Friday about a screening tool that's going to help with identifying eye conditions, but the same referral system is still going to be needed after you found that they've got eye conditions. I think eye conditions, as I said, are frustrating, but if you are aware that they do exist, that they can hold you up, once you found out about them and you're working as part of a team, they are surmountable. I have a great relationship with my team at Royal Ride. Every time I see patients in the clinic, I send out an email at the end of the day to let everybody know where I'm up to with my patients, and it's a great relationship. So good luck, guys, with your stroke and your eye care conditions.
And it's going to be quite challenging to find eye care support where you might be. One thing you might be able to do to overcome that is if you just do a bit of a search about some of the ophthalmologists who might be in your local area if you don't have access to on-site eye clinics. There are, and a lot of those ophthalmologists will have an orthoptist usually working with them who should be able to see the patient. Worst case scenario is to get the patient to see the GP, and the GP can then try and locate them to see an ophthalmologist or an orthoptist as well. I do know I have a colleague who is working on, as their PhD project, who is working on referral modalities and guidelines in how to direct you to best locate and refer someone on. But that's still a working project there at the moment. So that sort of brings us to the conclusion of our presentation. Just wondering if anyone has any questions.
Thank you both. That was fantastic. That was a really good overview of all of the eye conditions and potential visual difficulties that can and do happen following a stroke. And I think it was a really good reminder about the subtlety of eye conditions and the frustrations that can stem from them. Good to be reminded of that. Thank you both. Pat asks, I've been told in the past that it is good to alternate the eye that is covered to avoid fatigue in each eye when it comes to diplopia. It sounds like this is not what should be done. How would we identify which eye is affected on an acute ward?
Neryla, that one to you.
Okay. This is where you need somebody with knowledge of what's happening, because as I said, if you put the cover on the good eye, on the unaffected eye, the muscles are going to send the wrong message to the brain and to the hands, and the person is going to have a lot of trouble finding things, walking. Let me see. If I was going to tell someone how to try and do it, I think I'd put the cover over one eye and ask them to touch my finger. If they touch it accurately, that's a good eye to cover. I'd then ask them to put the cover over the other eye, ask them to touch my finger. If they miss my finger, that's the wrong eye. How about that for instance?
Yeah, no, that's a really great example. Thank you. On to the next question. So, Michelle, this one might be for you. Deirdre from Horsham asks, when it comes to hemianopia, what are your recommendations regarding returning to drive?
Oh, no, that's for Neryla.
Oh, that's for Neryla? Okay.
Neryla's the queen of driving.
Yes, sorry, that is an area where I spend a lot of my time. There
Fantastic.
are very definite measurements that a person must meet in order to be able to drive following peripheral vision loss. On a chart, which if I hold my hands up is showing you a ring like this, that's equivalent to about 180 degrees. In order to drive, you must get 90 degrees of clear vision across the horizontal meridian. It is measured on something that is called a binocular estimate, which is available with ophthalmologists and optometrists. Not only must you get 90 degrees, it must be within 10 degrees above and below the horizontal meridian. In addition, within a ring of 20 degrees from central fixation, you must have a maximum of 3 missing points. If you can meet those 2 criteria, plus you are not allowed to have double vision within 20 degrees of central fixation, plus you must have 6/12 vision in each eye. If you can get those 3 criteria, you have then met the Australian vision standards, not New South Wales. These are the Australian vision standards. Do I sound like I'm being dogmatic? Do I sound like I do this all the time? Yes, I do. Do I sound like I'm telling patients this all the time? Yes, I am. I'm very nice about it. I actually do these tests. I sit down and I draw them and I say to the patients, this is what you've got and this is what you must have. Now, we've got a problem. And the patient will go, yeah, okay. I spend an hour testing patients, and the patients at the end of it will stand up and say, thank you very much. So what I think the patients are saying to me, thank you for explaining it to me. I understand. They're not saying, that's fantastic, let's go away and have a party. They're saying, thank you, you've explained it, I understand. It's not a good thing, but that's the fact. Can I go on and say that standard is there for the safety and protection of the affected patient? Okay. Sorry.
Absolutely. No, not at all, Neryla. I think we all appreciate that. And I know patients in particular do appreciate someone who has a very vast understanding of what's happening and actually takes the time to explain it to them. So thank you. While I've got you answering questions, this one has come through from a few people. How long post-stroke would you encourage a patient to see an eye care specialist if they've had vision changes and their glasses are no longer suitable? And also on this question, how do we know what type of eye specialist to refer them to?
Straight away is my answer to that one.
Yeah, exactly.
As soon as they're able to, they need to head off to the ophthalmologist. Yes, now the confusion is there's a number of ophthalmologists who only do certain things and see certain cases. If it is eye movement related and stroke specific, they do need to see a neuro-ophthalmologist, but they could see a general ophthalmologist, then that ophthalmologist would then refer them to a neuro-ophthalmologist. There are going to have patients who are going to come in who may already be under an ophthalmologist, especially if they have pre-existing eye conditions or retinal issues, or they've had cataracts done or dry eye. They could go back to that particular doctor, and then that doctor will refer them on to the appropriate person if they need to be referred on. But the question that is, as soon as they are able to go and see the ophthalmologist, if they have changes, they should be seeing that ophthalmologist relatively soon.
So Michelle, just on that as well, would you still encourage them to wear the glasses that, even though they've had vision changes regardless, while they're in the hospital?
Put the glasses on them, and if they help, yes. If they help, then if their vision's not going to be benefited from the glasses, then it's up to the patient to wear them. But if you put the glasses on and they say, oh, okay, that's helping me, then yes, advise them to wear the glasses.
Terrific. Yeah, thank you.
If there's pathological changes, the glasses aren't going to make any difference.
Okay. No, that's good. Hayley, I hope that's answered your question. Jane has shot one through on our chat function to ask, in terms of nystagmus, do you work with physiotherapists to determine if there's a vestibular component?
Do we work with physiotherapists?
Not really.
Okay.
Yes, sorry, Michelle, I do.
Oh, you do? Okay.
Sorry.
Depends where you are. So
Yeah, no, I have a lovely time with physiotherapy. I go around to the physiotherapy department and use mobile phones while the physio is doing their physio treatment. They use their mobile phone to test their eye movements for me.
Okay.
Because that way and it's fantastic actually, because physios doing their training of their limb and head movements, and I'm doing my cortical function of horizontal and vertical movements, and I find out much more than I can do if I bring them into the eye clinic. Yeah. It's fantastic. So yes, I'm very happy to work with physios doing anything and everything. I work with a speech pathologist as well, who have a lovely time at Royal Road.
Sounds wonderful.
Sorry.
Just no, that's okay. We've also had, just while we're on nystagmus, what is actually recommended to improve nystagmus?
My experience with nystagmus is to try and get eye movements going. As I mentioned before, a very basic exercise for orthoptists is a thing called the Union Jack, where you get people to keep their heads still and move their eyes to trace out the plus and the multiplication sign of the Union Jack. And you've got to keep their heads still and move their eyes in all those directions. And it does or it doesn't work.
Okay. That's good feedback. One that's come through, again, from an anonymous attendee is, would you be able to clarify the red band that you recommend for peripheral vision difficulties?
Sorry, the red vision.
The red
And
band. The red
red
band.
red bar.
That's a Vision Australia thing.
Okay.
If you've got a book, yeah, can you see my book there?
Okay. Yep.
Yeah, okay. And the patient is reading the right-hand page. Yeah. And so, and they've got a left hemianopia. You say to the patient, start off where, find that, it's purple in this case, find that purple bar, and they do. And so you say, read along the line, and they might have to put their finger underneath it to read along the line. You've got to the end of the line, now come back to the purple bar to start the next line. Do you follow?
Yep.
Come back to the purple line, so it's a guide.
Okay.
Get you going. Yeah.
A great way to explain it. Thank you. Jenny from Port Macquarie, we're whipping through here. We've got 3 minutes left, guys. Jenny from Port Macquarie would like to be able to educate and support patients better around vision post-stroke. What do you recommend is the best way to do this? You've mentioned Vision Australia. Is it good to get in contact with them quite quickly?
Educate patients about stroke or about vision defects?
About vision defects post-stroke. So educate and support them around their vision.
Port Macquarie's got some good orthoptists.
There you go, Jenny. You've been told.
Get in touch with the ophthalmologists up there and ask to speak to their orthoptist and see what space they've got to come and talk to you and spend some time with you. No, I was on video with them the other night. They're brilliant. They're great orthoptists, actually.
Okay, no, that's really good to know. So we do have an interesting one here that's come through from Jody. Sometimes I feel my eyes jump and it can feel quite disconcerting. Does a patient with nystagmus feel those involuntary eye movements?
Probably. It's a bit more rhythmical, isn't it, Neryla, with nystagmus? It's rather than the jumping.
Yeah, I think before I say anything about that, I'd need to test that person concerned to see what we're talking about.
Okay, and then our last one. Yeah, sorry, Michelle.
I was going to say, but that feeling that she's getting, yeah, that would be similar to what they're experiencing. So she can have empathy there for them.
Thank you. The last one that's come through is patients in the community often see an optometrist for visual field testing, binocular Easterman. Is this sufficient or should they always see an ophthalmologist?
No, legally, optometrists and ophthalmologists can do the peripheral vision assessment to send through to the licensing authority. I'm choosing my words very carefully here because this is across Australia, so I'm not saying New South Wales bias, but no, both groups. I get to see a lot of baseline problem patients to give opinions and educate patients. And they come from optometrists and ophthalmologists, so you're sure.
Okay, no, that's great. And we're going to sneak one more in, and just as it turns 3. You mentioned the Union Jack exercise that's effective in helping to treat nystagmus. How long do you persist with doing that exercise before you decide if it is or isn't being effective?
Oh, how long was a piece of string?
Right, yeah. It's a tricky one, isn't it?
Yeah.
Yeah.
The upside of that is if you're giving your patient something to do, so mentally it's making them that they're achieving something, even if it's not a fast outcome. So from that aspect,
Yeah.
that can have a positive as well.
No, that's a really good point. I'm going to wrap it up there and hand back to Ash to finish up, because I am conscious it's just turned 3 o'clock and we have very busy clinicians who've joined us. So Ash, we're handing it back to you.
Oh, I'll just go back to them.
Wonderful. Thanks, Leah. Well, that brings us to the end of our session. Thank you so much, Michelle and Neryla. It has been really fantastic to learn from both of you today. And thank you, everyone, for your fantastic questions. If you haven't already, please make sure to register for part 2 of this series, which we will be presenting at 2 p.m. Australian Eastern Standard Time this Friday, the 12th of August. And in that session, that's where we're going to be talking about the vision screening defect tool as well. So there were a few questions that came through about that today. So if you want to hear about that, you need to register for part 2. You can also register for a CPD certificate for attending today's session by completing our survey. It should already be loaded onto your browser now. If for some reason it hasn't, I've just put a link to it in the chat for you as well. And those CPD certificates will be sent after the survey closes in a week's time. Thank you again, Michelle, Neryla, and Leah, and we look forward to seeing you all again on Friday for part 2. Bye for now.
Fine. Thank you, Ashley.
Bye.